Now we're going to turn to the next item of business, which is topical questions. Our first question today is from Jackie Bailey. Jackie Bailey.
To ask the Scottish Government what the daily average of COVID-19 tests carried out last week was.
Cabinet Secretary Jean Freeman.
During the week commencing Monday 25th of May, there were an average of 4,624 tests carried out on the Scottish population each day. This does not include the numbers for home testing.
Jackie Bailey.
Can I thank the Cabinet Secretary for her response? This figure falls well short of the promise made by Nicola Sturgeon that we would have 10,000 tests a day by the end of April, which was subsequently revised to 15,000 tests a day by the 26th of May. Indeed, yesterday was the lowest number of tests carried out, only 2,729, and only 937 new people tested. These figures are the lowest for months, and only 2.1% of the population has actually had a test. So can the Cabinet Secretary explain why testing is not even a third of the capacity available in Scotland and considerably less than 10% of the number of tests routinely carried out by the NHS in England? And can she also explain why we have one of the worst testing rates in Europe, if not the world?
Cabinet Secretary.
I thank Ms Bailey for that supplementary. Let me correct a couple of things, though, before I respond to it. First of all, the First Minister did not say that there would be 10,000 tests a day. What we said and delivered on was an initial increase in capacity to 8,000, and then a further increase in capacity last week to the end of May of 15,500. That is capacity. That is not the number of tests per day, and in both of those, the capacity commitments were delivered on. In terms of how the testing capacity is used, it is used in two ways. The first of those is largely demand-led, so it is led by those key workers now across a range of sectors, and including now everyone over the age of 5 who have symptoms to go for a test. And that is primarily done through the UK Government regional testing centres and processed in the Lighthouse Lab. The NHS labs are delivering on tests taken for those over 70 who are admitted in a hospital setting. At the moment, that is clearly a reduced number given the pause that we have put on so much of the NHS work. Those in ICU, as Ms Bailey will know, we're fortunate that that number is reducing. Those in hospital, clearly, for COVID, and also in our care homes, and that care home testing is being rolled out. Many of our board areas have now completed their care home testing of those homes with cases and are working through those care workers in homes where there is no active case at this point. The capacity that we have created, and we need to go further, is in order to ensure that we have the capacity in our NHS system in order to cope with what may be the demands that come as a consequence of easing lockdown measures and seeing an increase in the transmission of the virus, which we will then deal with through the Test and Protect system.
Jackie Bailey.
Can I thank the Cabinet Secretary for that further response, although I am surprised at her defence, because I'm sure she would agree with me that there is absolutely no point in having capacity unless you're actually going to use it. Let me say the Cabinet Secretary has made a number of announcements about extending testing, which she's outlined, twice in March, 3 times in April, twice in May. That suggests that the eligibility criteria were far too narrow to start with and remains too narrow now. The World Health Organization told us months ago that asymptomatic people were carriers too, and the more that were tested, the better. Given that we're now moving to the test and trace phase, where testing will be critical to managing a return to work, will the Scottish Government finally follow the advice of experts at the World Health Organization, whose mantra is test, 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 or are our clinicians more expert than those world experts?
Cabinet Secretary.
A number of points. First of all, what I said in response to both those questions wasn't a defence, it was an explanation. And secondly, eligibility was increased as the evidence that appeared suggested that it was possible to increase. But more importantly, let me just quote from the World Health Organization with respect to asymptomatic individuals. We have consistently taken a precautionary approach in relation to asymptomatic or pre-symptomatic transmission. On April the 2nd, the World Health Organization statement said there has been no documented asymptomatic transmission. As the First Minister has said, as I have said, in the early days of this pandemic, the clear advice that we were receiving from scientific experts and from our clinical experts was that there was no transmission from asymptomatic individuals. That has changed over time. I have to say there is still no set view on the part of the scientific or clinical community on this, and also on the difference between being infected and being infectious in those individuals who are asymptomatic. Nonetheless, taking that precautionary approach, that is why we have introduced testing to care workers in care homes where there is no active case and those care workers have no symptoms. And we will continue to consider, as we look to remobilise our health service, in what way further testing can assist us to do that safely.
Thank you. Brian Whittle, to be followed by Liam MacArthur.
Thank you, Presiding Officer. Cabinet Secretary, given the need and the important need to get the R numbers down, wouldn't it make sense to focus all that spare capacity where the biggest impact from COVID is being felt and where the highest R number now resides, in our care homes?
Secretary.
But that is precisely what we are doing. We are testing in our care homes, in those care homes with an active case, all residents and all care workers. And we are testing in those care homes, care workers where there is no active case. So that is precisely our focus, as well as the work that is underway in the hospital setting. And as I've said, further consideration as we remobilise the health service, the debate we will come on to, as to whether or not testing can assist us to do that in terms of the safety of both patients and staff. But I need to remind members that what the test tells you is on the day in which the swab was taken, were you symptomatic of COVID-19 or not? It does not tell you whether you were symptomatic 2 days later. It tells you on the day. So if you're asymptomatic and you test negative, then that test has to be repeated. And that is precisely what we will do in those care homes which have no active case in testing care workers. It will be an iterative process, repeating every 7 days.
Liam MacArthur, to be followed by David Torrance.
Thanks, Presiding Officer. As I highlighted with the First Minister last month, giving people access to information, the level of testing that is taking place at a local level, is going to be key to building public confidence and securing compliance as we move ahead with Test and Protect. First Minister appeared to agree, yet there's still no sign of this data being made available to people in Orkney or across Scotland. So can I ask the Cabinet Secretary when the public can expect to be able to access this and other relevant information relating to Test and Protect?
Cabinet Secretary.
So we will be able to provide information shortly on the tests that are conducted through our NHS controlled facilities. That's not just our NHS labs, that's now our partners in 3 of the major universities and in the Scottish Blood Transfusion Service. Over the coming days, once we are sure that the evidence or the numbers that they are giving us through Public Health Scotland are robust and make sense, should bear in mind that sometimes a test may be taken in a particular board area, but actually processed through a lab in another board area in order to ensure that we meet the timelines that we need to meet of as close to 24 hours as can possibly be managed. What we won't be able to do, though, is break down the number of tests that go through the Lighthouse Lab, because we get that figure for Scotland as a whole, not necessarily for different parts of the country. But we're working to make sure we can give as clear and robust data as we possibly can, and as soon as we're ready to publish that and with what frequency we will update it, I'll make sure certainly that Mr MacArthur knows that.
David Torrance, to be followed by Alison Johnson.
Thank you, Presiding Officer. The Cabinet Secretary mentioned the importance of flexibility when it comes to scaling up contact tracing, depending on demand. Can she outline how the Scottish Government will be assessing the demand?
Cabinet Secretary.
So the assessment of the testing capacity that is needed comes by pulling together all the information we have. So we know the numbers that we need to test in terms of existing 70-year-olds, for example, being admitted to hospital. We will be able to project that number as we look to restart, for example, elective care in our NHS. We know the numbers that will come through in terms of health and social care key workers, although that is a declining number. And we know what our care home demand will be in us, both as we go through the testing of those with active cases, but also increasingly continue to test care workers in those homes that don't have active cases. We also then get the demand from the modelling estimate, which produces for us our number, but also the number of individuals across Scotland who it is anticipated have the virus. And of course, through the work on test and trace, test and protect, where the message that we're sending to the public is a different message from before. The message now is, if you have symptoms, please get in touch with NHS Inform or NHS 24 and book a test. All of that's factored into the modelling, which takes us forward in terms of how much more than a capacity of 15,500 do we need to have for testing in Scotland.
Alison Johnson.
Thank you. On the 18th of May, the Scottish Government widened access to testing so that anyone with symptoms could get a test and introduced routine testing for 53,000 members of staff in care homes. At this point, before these changes, 5,000 tests were being carried out each day. And as we've just heard, since then, the number of tests has actually decreased. To test staff in care homes weekly, some 7,000 plus tests would have to be carried out each day. So can the Cabinet Secretary confirm that this is the Scottish Government's intention? And if so, when will this start?
Cabinet Secretary.
So it has started. The first thing I need to say is that the drive-through test numbers, in other words, those regional test centres, the numbers there, which is largely that wide eligibility group of anyone now over the age of 5 who has symptoms, has declined over the recent period. And to a degree, that is not a surprise, in as much as our number is reducing. The level of the virus at the moment in Scotland is low, and so you would reasonably expect a lower number of individuals to have symptoms and to seek a test. In terms of care homes, that work has begun, and all the boards have now produced plans which identify the priority in which they are going round the numbers of care homes that they have, undertaking the testing, including those where there is no case and it is care workers that they are testing. There are a number of glitches, I would say, in the path there. One of them has been, up until a week ago, those care workers who were reluctant to be tested because their terms and conditions from their employer was such that their weekly income would reduce significantly if they tested positive. We have now acted as a government to resolve that impossible dilemma for them. Of course, individuals have to consent to be tested, so we cannot expect 100% of the number to give their consent to be tested. And in some instances, particularly care home residents, where consent is not possible because of the conditions that they suffer from, the clinical decision would be made that this particular test would cause too much distress to force it on someone. And of course, you can't force a test on any individual. But in those circumstances, of course, testing is not the only route by any means, care homes should be preventing the transmission of the virus between one resident and another. They should be following the guidance clearly issued and reissued from the 13th of March onwards.
Thank you. Question number 2, Miles Briggs.
Thank you, Presiding Officer. To ask the Scottish Government what its response is to reports that there's been around 600 more deaths in care homes from COVID-19 than officially recorded.
Every week, the National Records of Scotland, NRS, publish the number of registered deaths where COVID-19 has been recorded by a medical professional on a death certificate. NRS figures show that there are 2,350 excess deaths in care homes during the pandemic up to their publication last week. Of this, 74% had COVID-19 recorded on the death certificate, either as a suspected or a probable factor in the death. Of the remaining 601, the doctor who certified the death did not record COVID-19 on the certificate, either as a cause or suspected cause of death. Scottish Government, with Public Health Scotland and NRS, are working to explore excess deaths as part of a wider piece of work to understand the impact of COVID-19 on the population.
Miles Briggs.
I thank the Cabinet Secretary for that answer. For several weeks, the First Minister has repeatedly suggested that the UK Government was undercounting the number of care home deaths, but this now appears to be the case in Scotland. So can the Cabinet Secretary say how many deaths there have been in care homes where people have been removed from a care home to a hospital setting? Does she know that figure? Does the Cabinet Secretary also now accept that at least in some of these cases, excess deaths in care homes that have not been recorded as COVID-19 related could actually be COVID-19?
Cabinet Secretary.
Well, in response to the latter part of that question, neither I nor Mr Briggs are clinically qualified, and so I wouldn't gainsay the professional reputation, competence or expertise of those medical practitioners who take exceptionally seriously the signing of death certificates, nor would I have the audacity to question whether or not they had recorded these matters properly. Secondly, the First Minister did not suggest or state anything to do with how other countries in the UK record their figures. She simply spoke in detail about how we record our figures, and the member will know that very clearly. In terms of where deaths are recorded as happening, of course there's no gap here. NRS figures, I'm sure Mr Briggs is as familiar with those weekly publications as I am, give the location of the death. And so if the individual who died was not at home but was in hospital, it would be recorded as a death in hospital. It was not a missing death, it's recorded as a death in hospital. If the individual was in hospital but not in the care home, then the death would be recorded in hospital and not in the care home. So there's no suggestion here, I hope, that there is any dubiety in the figures that NRS record and publish, and do so to the professional standards that they are required to meet.
Miles Briggs.
Thank you, Presiding Officer. Last week I asked the First Minister how many patients in hospital without a power of attorney have been placed into care homes. First Minister has still not responded to me, so can I ask the Cabinet Secretary if she can provide that information today? And also, has she investigated any of these individuals who may have had a do not resuscitate order placed on them? And what legal framework are Scottish ministers using in both these cases?
Cabinet Secretary.
So, first of all, I have to say that in terms of those individuals who are currently in hospital when they are clinically able to be discharged, but they are there because of adult with incapacity legislation. That is legislation. It is not something Scottish ministers decide. It will be a decision taken primarily by the designated mental health officer of the local authority, and there are various processes that individuals have to go through. In terms of the actual numbers, without advance notice of that supplementary question, no, I do not have those, and I'm sure the First Minister will respond to Mr Briggs as she committed to. In terms of DNR, I'm sure Mr Briggs will be aware of the actions that both the former CMO, the current CMO, the Royal College of General Practitioners all took to ensure that our general practitioners across the country and our clinicians in hospital understood the proper process to go through in terms of agreeing with the patient whether a DNR notice should be placed or not. There have been instances where that appears to have been taken inappropriately, and in all of those instances we have contacted the board or the relevant practice, or a CMO has, the relevant practice concerned, and ensured that individuals in those circumstances understand the way in which both DNR but also advanced care planning needs to be undertaken.
George Adam, to be followed by Neil Findlay.
Thank you, Presiding Officer. Can the Cabinet Secretary provide some detail on how excess deaths in recent weeks compares in Scotland with that of other parts of the UK?
Cabinet Secretary.
So there are two figures, I think, that may help. So in the period between week 11 and week 21 of the pandemic, excess deaths in Scotland were 39% higher than the equivalent period that is being compared against, 50% higher in England and Wales. In week 21, that is the week for which the figures are most recently available, excess deaths in care homes in England and Wales, 63% above the 5-year average, Scotland 42% above the 5-year average. So those are the figures. I need to also say, though, Presiding Officer, we're not engaged in some kind of competition here. Any one of these deaths is a death to be regretted and, of course, leaves the family and their loved ones devastated and grieving. And every single day, we at the briefing and here in this chamber, if we're not at the briefing, make that very clear how seriously we take those numbers. But it is important, as we have said already, to have all of these matters in a clear perspective and be accurate.
Neil Findlay, to be followed by Alex Cole-Hamilton.
Presiding Officer, I previously asked a written parliamentary question to ask the Scottish Government how many people had been discharged from hospital to care homes since February the 1st and how many have subsequently died. Mr Briggs asked a similar question and I noticed the Cabinet Secretary didn't answer. So I wonder if I could ask again, is the Government going to pursue that and collate that information and publish it? Because the answer I got is that this information is not held centrally. It's a very, very important point.
Cabinet Secretary.
And Mr Findlay is correct in that the answer was correct. That information is not held centrally, but we are working with the various teams concerned to see how much of that information we can gather. I cannot commit that we would be able to gather it in 100%, but as that work is progressed, then I do undertake to make sure that Mr Findlay is updated with how far we are getting and how robust we think that information is. And at the point, as with all this information, when we believe it to be robust, then we will publish it.
Alex Cole-Hamilton.
Thank you, Presiding Officer. A constituent contacted me last week whose daughter works in a care home in the north of Scotland. She recently processed the arrival of a resident who'd been transferred from the Home Farm care home on Skye to that home. That resident then subsequently died of COVID-19 within a week. So can I ask the Cabinet Secretary, how widespread is the transfer of residents out of COVID outbreak homes and what infection control measures are put in place to do that safely?
Cabinet Secretary.
So I don't have the answer to the first part of Mr Cole-Hamilton's question. I'm not sure if it is possible for me to acquire those numbers, but I am certainly prepared to undertake to consider that and look and see if we can and let Mr Cole-Hamilton know that. The second part of his question, though, is really important, and that is infection prevention and control measures. All care homes at all times, pre-pandemic and since, should have adequate infection prevention and control measures in place. We all know that every winter our care homes suffer from norovirus to varying degrees, that flu is part of seasonal activity in winter and the older residents are particularly vulnerable to both of those. So all care homes should have very, very clear and updated infection prevention and control measures. But in addition, in terms of the current pandemic and the current situation, of course, the guidance that was issued on the 13th of March was very clear, and every piece of guidance subsequently has been very clear. The current work that is underway about isolating individuals in their own rooms if they have symptoms or they have come from a COVID-19 setting, in order to ensure that even if they had tested negative, we do that for the 14 days to be sure that no symptoms do emerge. Growing knowledge about the range of symptoms, particularly in older people that are there, that appear to differ from those of a different age group, as well as all that guidance about the ending of communal activity, communal dining and so on. And now, in recent weeks, the direct involvement of our Directors of Public Health and our NHS clinical teams in ensuring that all those care homes are practising the requirements that have been theirs to meet for some considerable time. And, as the member will know, the Care Inspectorate is undertaking a number of inspections of care homes across the country, on-site visit inspections.
Thank you very much. Question number 3, Emma Harper.
Thank you, Presiding Officer. To ask the Scottish Government whether it plans to update its advice for people who are shielding.
Cabinet Secretary.
We do plan to update that advice. That should not be taken at this point as any indication that that advice will necessarily change. But we do know and recognise that those who are currently shielding, who are the group of people of whom the most has been asked in this recent period, that they want to know what will happen next and what that means for them. We need to ensure as best we can that the approach we take is the right approach, so led by our Chief Medical Officer and his advisory group of clinicians. They are working through whether or not they believe there is any possibility of easing the current restrictions on that group or not at this point, as we come to the end of the first period in which we asked people to shield. They're working through that in order to provide clinical advice. What we will make sure that we do, though, they're working to a timetable that ensures this, is that individuals in that group will be given that clear advice in advance of the end of the current shielding period, advice about the level of risk that those clinicians believe individuals face, about what we are asking them to do to shield themselves against that risk, what they individually can do, and importantly, advice for those who are supporting them about what they need to do in order to ensure that they mitigate risk, and, of course, what support we will continue to offer individuals in that group and to ensure that they have access to medicine, to food and to other support that they might need.
Emma Harper.
Thank the Cabinet Secretary for that response. Given that advice in England has diverged from the rest of the UK and people in the shielding category are now being advised that they can meet other people, despite the medical and scientific evidence suggesting that it's too early for this course of action, can the Cabinet Secretary provide assurances to those shielding that this step will only be taken in Scotland when the advice and evidence suggests that it is safe to do so?
Cabinet Secretary.
Yes, I can. That's why we have not made any pronouncements so far. And I understand that that can be difficult for people in Scotland who are in that group, who see apparent changes in England and in Wales and nothing so far here, which is why we have made such an effort to continuously say, we have not forgotten you, you do matter, and we are working on this because you are so important. We are also making sure that we hear from those who are currently shielding. So since the 29th of April, we've been undertaking research interviews with people who are shielding, and until the 14th of June, people who are shielding can also respond to a Public Health Scotland survey, which they can find at surveys.publichealthscotland.scot, so that we can hear from them about what matters most to them and try as best we can to weave that into the advice and the guidance that we give.
And Emma Harper.
Thank you again, Cabinet Secretary. We saw reports over the weekend of vulnerable people in England being told they have been removed from shielding lists via text message without even the knowledge of their own GPs. And the Cabinet Secretary talks about advice given to shielding people. Can the Cabinet Secretary outline how the Scottish Government will communicate any changes to guidance with those who are currently shielding, and will there be flexibility for people to adapt their behaviour in consultation with their own clinicians?
Cabinet Secretary.
So the shielding list, as I'm sure Ms Harper and others recall, was drawn up in the first place by the 4 CMOs, in agreement between the 4 CMOs of the nations of the United Kingdom. My understanding is that the removal of some of the clinical groups from that list for England was not agreed between the 4 CMOs. We are not currently intending at this point to do that, although the clinical group that I mentioned is looking very carefully, not at removing people from the shielding group, but whether or not advice, depending on the condition, should vary, or whether that is too early for that to happen. The clinical groups on the shielding list, as you will know, have altered over time, and of course it remains possible for an individual GP or consultant clinician to add someone to the list if they feel that they should be on it. Splenectomy, for example, was a group recently added to that list. But in terms of how we will communicate with people, once we have that clinical advice, then we will be communicating with people as we did in the outset, and that is a very detailed, clear letter, a route to go if you have further questions, who you should speak to about your personal situation, where you go in order to get that locally delivered support. There may be some people who didn't register for support first time round, but will need it now. So again, repeating all of that, but giving people all of that information and advice and guidance in advance of any change that we are going to introduce, so that they have time to ask questions, to understand what any change involves, and to arrange how they are living to accommodate that, if that is what they wish to do.
And Willie Rennie.
There are those who are in the over 70s group who are unclear about what the guidance is for them. Some have been following the shielding guidance, even though they're not on the shielding list. When the new shielding guidance is out, will there be a revision for the over 70s as well?
Cabinet Secretary.
So I think what is fair to say, precisely because of the point that Mr Rennie has made, is that there will be clarification for that group of people who are not on the shielding list but are over 70 years old or are in the group of people who currently are eligible for the flu jab, about how they have the same restrictions as everyone else imposed on them, but need to take additional care in terms of being outside, in terms of the 2-metre distance, the wearing of face coverings and so on. So we will look to ensure that people no longer feel that the shielding advice applies to them, but are clear about what advice does apply to them, and have that clarity with additional advice that says these are the reasons why we believe you need to take additional care to the 20-year-old grandson that you have, or the 40-year-old daughter. This is why you need to take a bit of additional care, and here's what that additional care should be.
Thank you very much, and that concludes topical questions.